fetal morbidity and mortality. Identifying biomarkers is a promising tool in understanding the pathogenesis, early prediction, and prevention. To shed some light on the topic, Dr. Sarosh Rana is live with us on webinar. She is the section chief at Fetal-Maternal Medicine Unit at University of Chicago. And her research over the last several years has focused on clinical utility of angiogenic biomarkers in prediction of adverse outcomes in women with preeclampsia. Let's hear from the expert.
Dr. Sarosh, can you hear us?
Yeah, I can hear you really well.
Yeah, you're on. You can go ahead.
Can you guys see the slides?
Yes, clearly.
Okay, very good. So hi, so here is actually, let me see, it's now it's 2:35 in the morning. So I think it's good afternoon for you guys. So good afternoon, everyone. So we're gonna talk about, I don't know who was introducing me. Was it Revati? But if whosoever it was, thank you so much for introducing me. So my name is Sarosh. I'm actually at the University of Chicago. And we'll talk about these biomarkers that were actually now been in the market for a few years that we think can potentially be used for a prediction of some of the adverse outcomes that relates to preeclampsia. Now this talk, it's only for 30 minutes, so I'm not going to go into a lot of details about kind of building up the literature. I'll definitely go through it, but mostly talk about this, one of the new studies that we did just published in Chicago. So I do have some conflict of interest. There are some companies which are actually trying to develop the assay, and it's in India, I know that it's available on the Roche platform. So I've worked as a consultant in some of these companies as they're trying to develop it. I think what we'll do is maybe we can spend like few minutes to talk about the pathophysiology of preeclampsia. I'm pretty sure everybody understands that, but just in terms of how the biomarkers that we're going to talk about fits into the current understanding. And then like I said before, we'll talk about the role of these factors, not so much as I've been talking a lot, and I know a couple of years ago we talked about the use as a rule out test. So you want to rule out preeclampsia. Today we're going to talk about mostly about the role of angiogenic factors, as perhaps we can use it as a rule in test to see who is the patient who's going to develop preeclampsia. So you guys all know this, it's a common hypertensive disorder pregnancy. Preeclampsia and ACOG just very recently changed the definition. So we don't have proteinuria in the definition anymore. You can have preeclampsia without proteinuria, but it's essentially when I say, in my mind, when I look at it, I say it's characterized by high blood pressure, so hypertension, and some sort of an end organ damage. So you can have obviously seizures, you can have all those things that are going on, but in the context of hypertension. At least in US, the incidence is 5 to 7%. I know there are certain parts of the world where the incidence is quite high, and you guys know that it's responsible for a lot of maternal deaths and fetal deaths. So certainly finding biomarkers or certainly finding tests that we can predict preeclampsia or adverse outcome faster, I think will be a way to kind of, because it's responsible for a lot of maternal and fetal deaths. Now, most of the deaths that occur from preeclampsia are in the context of seizures. You guys again know that, much more common in, for example, India and Africa, and also from bleeding. And most of it is really antepartum bleeding from hemorrhage and postpartum bleeding as well. It is in the US a leading cause of prematurity. So currently in the US, about 50% of all babies which are born iatrogenically are because of some sort of a hypertensive disorder pregnancy. So it's a very relevant disease for all the obstetricians. And one of the reasons I got involved in the field was over and over again in the textbook, and as I'm seeing patients, it often presents atypically. So there can be patients who have HELLP syndrome, who can develop HELLP syndrome, who have no hypertension. You can have eclamptic seizure without a hypertension. And currently, and we don't have time to talk about it, but there are certain novel therapies available that people are working, but currently there's no treatment. And so the treatment is delivery. So somehow figuring out who's the patient at risk, I think, is important. And again, maybe a topic for another time discussion, but you guys should certainly discuss that preeclampsia is associated with long-term cardiac and renal complications, especially cardiac complications. It's associated with about more than twofold increase in the risk of CVD in women who have history of preeclampsia. So when I look at preeclampsia, so we know it's a placental disease, a little, just one slide about at the kind of at the cellular level, what's happening. So I don't know if you guys can see the pointer, but you have these villi, which are the fetal cells. It's lined by these layer of cells called syncytial trophoblast. And then you have these cells called cytotrophoblast. So in normal pregnancy, this is your maternal side. You have the myometrium and the endometrium. So in the normal pregnancy, these cytotrophoblast actually invade the spiral artery. You can see that down here. And what happens is that with the invasion of the cytotrophoblast into the vessel wall, the spiral artery becomes really large, and it has very, very low resistance, and a large amount of blood volume is actually flowing in the intervillar space. So essentially what happens so it's just a cartoon, you have an unmodified spiral artery, which is in a non-pregnant, for example, it'll be lined by an endothelium, it'll have a thick muscle wall. While if you have normal pregnancy, when you get pregnant, these spiral arteries get modified, and they are trophoblast modified arteries, which are lined internally by the cytotrophoblast. They are large vessels, and they do not have so much of that tunica media. So if you look under the microscope, you can see that this on the top panel, you can see those spiral arteries, which are very thick and which have small amount of lumen compared to when you're pregnant. You can have these very large lumen vessels, which almost have no muscle wall. And in preeclampsia, it's kind of believed that there is shallow invasion. So cytotrophoblast, they invade superficially, so they don't reach the myometrium, for example. Here, they're only reaching the endometrium, and hence they're not able to invade the spiral arteries. So the spiral artery invasion is quite superficial, and essentially there's a hypoxic environment, so there's less blood that's flowing into this intervillar space, and that's kind of the key reason why women have preeclampsia. So this is a recent article that we just wrote in, I think, a couple of months ago. So now it's kind of established that it's two stage. So the first stage is the first and the second trimester when your patient is asymptomatic. So it's the stage of abnormal placentation. And what's going on is that you have all these different factors. You can have genetic factors, environmental factors, immunological factors. All these factors are causing somehow this abnormal placentation. So there is invasive cytotrophoblasts which have superficial invasion. There are narrow metal vessels, and placental ischemia is kind of the key to drive preeclampsia. And there is lots of evidence that you have evidence of persistent hypoxia. So some of the key signature proteins, such as HIF1, autoantibodies, there's evidence of mitochondrial stress in the placenta derived from women who have preeclampsia. So that's all happening when the patient is asymptomatic in the first, second stage. And then you have this second stage in the first, second trimester. Then you have this second stage where this diseased placenta now releases some of these circulating factors. So the factor we're going to talk about is called soluble FIT, but there's actually very good evidence and very recently very good papers that there is release of syncytial debris. So essentially, the placenta is releasing these debris and vesicles, which are actually full of proteins and pro-inflammatory cytokines in the maternal circulation. So once you release all these cytokines and you release these factors, it goes to all across the body, and then it causes systemic vascular dysfunction, and that's when you get actually the clinical disease. So then you can get proteinuria, you can get glomerular endotheliosis, hypertension when it affects your systemic vessels, it can affect your brain vessels, so you can have visual symptoms, headache, cerebral symptoms, and it can also affect the coagulation. So essentially, um, there is good evidence from animal and for all kinds of studies in vitro studies and human studies that there's release of factors in the maternal circulation. So it's a systemic disease. So what we've kind of come to the conclusion that preeclampsia is essentially an anti-angiogenic state. So if you bear with me for one more kind of this molecular biology lecture. So essentially what happens is that you have these receptors, which are called VEGF, so it's vascular endothelial growth factors. And these are kind of the growth factor receptors which are present on the cell surface. And then soluble FLIT is a truncated protein. So it's a spliced variant. And essentially what it has this binding domain. So it binds to VEGF and PLGF, but essentially does not have a transcellular domain. So when you have excess soluble FLIT, as shown in this picture here, most of the VEGF and PLGF is actually bound to soluble FLIT. So there is less amount of VEGF and PLGF that remains to bind to its native receptor. So there is insufficient VEGF signaling, endothelial dysfunction, and then hypertension. So essentially, how it translates to clinicians like us, that if you were to look in serum, or in the plasma of the patient, your soluble fat protein will be high and your PLGF will be low. So one of the things that we kind of early on did this study was, it's kind of relevant, is when we started looking at uh, people, patients who would and would not have adverse outcomes. We actually found we took 100 patients who came to the hospital and were diagnosed and were admitted with either diagnosis or evaluation of preeclampsia. And essentially what we found was that when we divided them into patients who have a high ratio and a low ratio, so the top bar, the top graph, the red ones, so these are sequential samples. We collected samples for the first 3 days and then weekly. And essentially what we found was the patients who came in with a higher level. So here we divided them as a level of 85. If they came at a higher level, they continued higher and they continued to rise, they got delivered really fast. While if you have patients who in the top, if you look at this graph, which have these green lines, if you have patients who came in with low levels, so these are less than 85 and they continue to have low levels, these patients actually remain pregnant faster. So here, for example, the latency was 6 days in patients who had a high level, while it was 14 days in patients who had low levels. And then we calculated a positive predictive value. So I talked a lot about a negative predictive value. I don't know if you guys have read the trial, the prognosis study. There was a prognosis Europe, there's a prognosis Asia, which just got published. And they came out and they said the negative predictive value of a soluble fat PLGF ratio was close to 99.9%. So in their studies, the hypothesis is that if you have a soluble fat PLGF ratio in triage in patients who are less than 37 weeks of less than 38, you actually do not develop preeclampsia. Here we are trying to figure out what is the positive predictive value of the test. And at least in this study, we found that the positive predictive value for delivering the patients within 2 weeks, if the ratio was more than 85, was very high. It was about 91%. The other kind of clue that we got was that we redefined our, so ACOG came out in 2013 and actually redefined the definition of severe preeclampsia. So now you have preeclampsia and then you have preeclampsia with severe features. So this is kind of another study where we looked at 400 patients who were coming to triage for analysis of preeclampsia, for diagnosis or either confirmed diagnosis or suspicion. And among these patients, when we analyzed them, there were 66 patients who developed preeclampsia with severe features with a new diagnosis of ACOG within 2 weeks, about 16%. So not very high, but also not very low. And essentially what we found very similar to our previous studies, that the soluble fat was high in women who had preeclampsia with severe features, PLGF was low, and then when you had the soluble fat PLGF ratio, it was higher in women um, who had preeclampsia with severe features compared to patients who had non-severe. So essentially, this is just from a table from that paper that was very recently published last year. So C statistic is a metric that you use for area under the curve. So the higher the number towards 1, the better the test is. And then we calculated sensitivity and specificity. So here we are looking for patients who developed severe features within 2 weeks. And we only looked among admitted patients. And the reason was because FDA is actually doing a study right now whereby we are looking at admitted patients for approval of biomarkers in the US. So here, when you look at it, we found that patients who were less than 34 weeks on enrollment, in terms of predicting their diagnosis of severe features, it actually had pretty decent positive predictive values, so 73 and 76. So just putting people in context, the positive predictive value of hypertension per se, just a blood pressure of 140 over 90, for prediction of severe features, for example, is quite poor. In some of the studies, it's as poor as 20%. So having a test with a positive predictive value that's anything better than the 20% that you get with your hypertension, I think is worthwhile. There's another kind of study that we did, just again kind of proving the point that high levels of soluble fat PLGF are actually associated with adverse outcomes. So this was Dr. Melissa March, who's one of my fellows. We went to Haiti because there are lots of these adverse outcomes that I talk about actually don't happen in the US. But there are lots of adverse outcomes that are happening. We looked at patients who had severe hypertension, who had abruption, IUGR. We had patients who had eclampsia, and then there were unfortunately many maternal deaths and fetal deaths. And essentially, when we measured the soluble fat PLGF, this was before delivery, we found that patients who had any kind of these adverse outcomes had a much higher level of soluble fat PLGF. So kind of telling you that if there is an associated adverse outcome, they kind of have a high level, at least at the time of diagnosis or just before the diagnosis, and they have very high levels of soluble fat PLGF. So why this is even relevant in where I am in Chicago, so I don't know if you guys know, but in United States is the only country in the developed world where the rates of maternal mortality is actually rising. And it's been rising for for a few years now. So if you look at this graph here, that's the US where the maternal mortality is 26 per 100,000, and rest of the countries, Finland, Denmark, they're very, very low. They're 3.8, 4.2. So this was an article that was published not by us, but by this group in California. And essentially what they came out is they looked at the California mortality for the past 10 years, and they said preeclampsia is a common cause of maternal morbidity and mortality. And then they said that there is evidence that about 60% of the deaths that are happening in preeclampsia, they have a good to strong chance that you can actually change the outcome if you had an intervention. So if you were to do just your regular interventions. And then they looked at the patients who died, and in those patients, they found that there was a delayed response to warning signs, because obviously the warning signs of preeclampsia, and you guys know that who practice obstetrics, is that the warning signs of preeclampsia are actually really bad. And then they also found that there was ineffective care because you didn't really pick up these patients fast enough. And there was a lot of misdiagnosis going on. So in cases of maternal mortality, what I was intrigued about was there's this very large number that if the mom died, there was in majority of the cases, it was just delay in response to the warning signs. So they were just like not recognition that this is something important. So what I did was we set up a study in Chicago to kind of pick up on that warning sign concept, saying, can we perhaps use these biomarkers to as a warning sign? So perhaps as you're looking at hypertension, headache, all these other things, you can say, well, maybe biomarker can be used as a warning sign in patients and see if they actually relate to peripartum morbidity, so not just the antepartum hypertension and antepartum preeclampsia, but also postpartum morbidity and postpartum hypertension even among patients who are hospitalized, because you have a great opportunity to intervene if you actually figure out who's at risk for adverse outcomes. So what we did was we did a prospective cohort study. So it's a set of pregnant patients who were coming to Family Birth Center at our institution between here it's years of 2015 and 2017. We essentially took all patients between 22 weeks and 41 weeks. And what we did was we collected their blood sample when they came in, and then every 3 days until delivery. For this analysis, we used the most proximate blood samples to delivery. So most of these samples were collected within 3 days of their delivery. We collected the maternal data we have the electronic medical record, and we entered into this kind of a centralized research electronic database. We also collected all the neonatal outcomes from the maternal and the neonatal charts. So we were looking at two things. One, we were looking at the hypertensive disorder pregnancy that was recently diagnosed as per ACOG, but also we were looking at maternal complications. So these are the different complications that we looked at in this paper besides the hypertension. So we looked at HELP syndrome, transaminitis, thrombocytopenia, high creatinines. We also included things such as transfusion of more than 4 units of packed red blood cell. That's actually a indicator for severe maternal morbidity. So not the mortality, but SMM is like a big thing. You have to like track how for every single maternal mortality, there are about 500 in some instances severe maternal morbidity. So maternal morbidity is actually so much more common. We also included DIC, abruption, maternal death. We didn't have any of these, but also eclampsia, cardiomyopathy, pulmonary edema. So anything ICU admission, anything that you can think of that can make your patient sick. Then we stored these samples at -80 until all the analysis was, until the time to actually do the analysis. We measured these ratio on this platform, which is actually pretty nice because it's called a Cryptor platform. It is by Thermo Fisher. And actually it's a tabletop. So it's a simple device that can sit on your table and is pretty accurate in terms of measurement of soluble fat PLGF, similar to the Roche platform that you guys have. But Roche machines are really large. They have to be actually associated with a lab. So I like this platform because if the test were to be available, you can actually use it in your clinics. The coefficient of variation for our samples was very small. It's a very accurate test. We did all the measurements after delivery on all the patients because the test is not yet approved in the US, so we can't actually use it in real time. So none of the treating physicians actually knew the assay results. So their diagnosis and their decision to delivery was actually not based on the assay results, but based really on the clinical findings, and the technicians who were doing the analysis were actually blinded to the patient's diagnosis. So what did we find? We had 681 women, and we kind of they were divided into two parts. There were patients who were hypertensive, so about 375, and out of these patients, a large majority, about 33%, actually had preeclampsia with severe features as defined by ACOG. And in our patient population, which is very different now in Chicago compared to the previous studies I've done in Boston, that they were large majority of them were African American. And African American patients were actually at much higher risk of maternal morbidity compared to white Caucasian. So when we looked at the demographics, again, it's kind of a busy slide, but essentially what I'm trying to show is who were these patients. So if you look at all these patients, the average age was 28, the BMI was 32, so they were all obese, a large proportion of patients. About 44% of the patients were nulliparous, 71% were Black, and then about 17% had a patient had a history of chronic hypertension. And obviously, all this is more worst when you're looking at this column of preeclampsia with severe features. They had a higher BMI, they had a high proportion of African American, and the significant number of patients had a prior history of preeclampsia or chronic hypertension. Did we pick out so whenever we make table 1, table 2, you have to like look at who are these patients again. So patients with preeclampsia with severe features are in this column. If you look at them, obviously they were defined preeclamptic, so they had much higher systolic and diastolic blood pressures. So the mean blood pressures were 174 over 103. They had large proportion of patients had proteinuria. They had elevated ALT, AST, and higher creatinine, and slightly lower platelets than normal patients. So again, this slide is just to show that patients that we were defining as preeclampsia with severe features at least met the clinical criteria that we typically define. How about the outcomes? So some of the outcomes that we looked at, for example, was betamethasone use, which was much higher in women who have severe preeclampsia. Again, makes sense. Women with severe disease actually get delivered preterm and they get betamethasone prior to delivery. Larger proportion of patients, 77% received antihypertensive, about 90% received magnesium. Their gestational age of delivery was much lower, 34 weeks compared to normal patients who were 38 weeks. Their birth weight was much lower, 2,200 grams compared to birth weight in normal patients, 3,000 grams. And they had a very high rate of preterm delivery, 67%, and high rates of C-section, such as 60%. And these are all very consistent with previously published data. What about angiogenic factors? So we found that, as previously published, patients with severe features had much higher levels of soluble flex, so 9,000 compared to normal patients, 2,000. The PLGF was also very low, so 51 compared to 212. So when you calculate that ratio, remember I told you the ratio is high. It was 212 in patients with severe features compared to 14 in patients who were normal. So you were clearly, a lot of this preeclampsia with severe features was driven by high soluble fat PLGF ratio. So then the original intent was to see if you can look at these patients and characterize them based on high and low levels. So essentially what I did was I took the hypertensive cohort, there were about 300 patients, and I divided them into patients who had a high ratio, so more than 38, and patients who had a low ratio, less than 38. And essentially here what we found was, among other things, such as the magnesium use was much higher here, is that a high ratio was really defining in the patients with chronic, with these hypertensive disorder, this high ratio was really defining a subset of patients who were at high risk for adverse outcomes. So if you look at the adverse outcomes that I defined before, the rate of adverse outcome in patients who had a high ratio was 20% versus 5% in patients who had a low ratio. And this is pretty baseline rates of adverse outcomes in patients, for example, who have chronic hypertension. They were more NICU admissions, they were more low birth weight babies. Definitely the rates of preterm birth, so less than 34 weeks, was 30% in patients who had a high ratio compared to only 4% of patients who had a low ratio. So essentially, and we also looked at postpartum hypertension, the rates of severe postpartum hypertension was higher and patients stayed longer. Essentially, we came out and said, well, if you had patients who have preeclampsia or any kind of hypertensive disorder on admission, if you look at their biomarker profile and if they are high, but they have a higher ratio of more than 38, they have a much higher rates of adverse outcomes compared to women who have a low ratio. And perhaps that's a reason that you can use that as perhaps a warning sign. Then we also created some tertile analysis. So this is, you can divide up your cohort based on a soluble fit PLGF ratio. And when we did that, if you look here, so these are, so the numbers that come out here is like you have first tertile, which is the reference, you have tertile 2 and tertile 3. And for any kind of biological phenomenon to be happening, your tertile 2 should have higher odds of having the disease than tertile 2 compared to tertile 1. And anything more than 2, as you all know, odds of more than actually 1 is a good odds. And here we found an odds of 22. So women with a higher in the third tertile of soluble fit PLGF ratio had a 22-fold higher chance of association or development of severe disease compared to women in the low tertile. So very strong association. We also found the risk of complications was much higher, just I just showed. When you convert it into odds, it was about 4.72. And then we looked at postpartum hypertension among women who had antepartum hypertension based on the soluble fit PLGF ratio. The odds ratio was 10. So what we concluded from this disease, from this paper, was that what was new here, that the angiogenic factors measured prior to delivery was associated with not just antepartum, but also postpartum complication, including we looked at resource utilization, betamethasone use, magnesium admissions, and risk of severe postpartum hypertension. I think what was also unique about this study was that the study was predominantly done in African American obese pregnant population, which is significantly at risk for adverse outcomes associated with preeclampsia. So what was relevant is that evaluation is these biomarkers, I believe, can stratify patients who are at risk for pregnancy for preeclampsia related complications, and perhaps you can then quickly transfer these patients to a higher level of care for appropriate management, and perhaps this could be life-saving and obviously clinically useful. So we came out from this paper and we concluded that angiogenic factors can then be used for risk stratification to identify patients who are at risk for severe peripartum complications which are related to preeclampsia. So this was, you guys can all find it. If not, I can send it to Revati. This was published in February 2019, and this actually got a lot of press. It was cited as one of the high impact papers in hypertension in the summer of this year, and most of the work was done by my fellow Joanna. So just, I think one more slide is that, so I went back and said, what about, people ask me questions, Dr. Anna, what about patients just with chronic hypertension? Can you just take with patients who have chronic hypertension and then divide them into high and low ratio? So here is a paper that's going to come out soon. I divided them into more than 85 and less than 85. And what I found was very nicely that if you have a high ratio among patients who have chronic hypertension, you can have a proportion of patients having adverse outcome 24% versus 3%. And I know Revati just finished a study. We're going to analyze it, where she took all these patients with chronic hypertension and managed them according to their soluble fit PLGF ratio. So I think there's definitely a good evidence that it is associated with adverse maternal outcomes even just prior to delivery. So I'm going to just summarize, and this is, I did not show you this data, but there is good evidence now that soluble fit rises prior to the symptoms of preeclampsia, so it can actually be used as a test for prediction. This was the prognosis trial that I talked to you about. It was published in New England Journal of Medicine in 2016, saying if you take a ratio of 38, it has a negative predictive value of 99%, so it can actually be used as a rule-out test. We have done studies in the past saying that it can actually be used, and today I showed you data as a rule-in test. And like I said, some of these existing things, such as hypertension, has a very, very poor positive predictive value. So I know I'm kind of running out of time, but this is what I feel my feeling is about how prenatal care is currently. So what you guys are all doing and what I'm doing every day is that we have this conventional approach where we are checking blood pressures and urine protein. And these are very non-specific. These are resource intense. They're positive, very poor positive and negative predictive value. And then, this is actually may lead to iatrogenic prematurity. What we think what should happen is that we should do biomarker-based assessment at the time of, and this was, I wrote that in the context of clinical suspicion, but you can do it in first trimester, second trimester. I think definitely at the time when you're clinically suspecting preeclampsia by some of these biomarkers and do individualized, personalized care. So you divide patients into low-risk patients who you can continue routine prenatal care and delivery, and you have these high-risk patients where you have higher biomarker. You can transfer them to a higher care facility. You can refer them to physicians with knowledge of the disease and perhaps access to a higher level of maternal care. And I think that will reduce the high burden of maternal and fetal death. So just two slides about what are we doing in the US. So the biggest challenge I face in the US, it's these biomarkers are actually not FDA approved. So I cannot use them to do any kind of interventional trial. So I cannot manage my pregnancies or any of the patients with biomarkers in real time. So we're actually currently doing an FDA study for the federal government to get these biomarkers approved for diagnosis and prognosis of preeclampsia. And the study is actually pretty much based on some of these studies that I showed, that we are collecting samples at the after admission, and we are looking for prediction of severe preeclampsia within 2 weeks up until the time of delivery. I'm just going to show you a US map here. So it's a 10-center study. Currently, it's being coordinated by Cedars-Sinai. That's where I am in Illinois. We'll have 1,000 patients across all US sites, so 100 subjects over each site over 2 years. And this will be the largest preeclampsia study in the US to get the biomarker approved. There's some acknowledgement. So for you guys to know, this is the guy who actually found this protein, soluble FIG. That's Dr. Karamanchi. I used to work in his lab when I was in Boston. That's my current chair, Dr. Lingao. Dr. Thadani does a lot of studies around treatment of preeclampsia, and that's Dr. Lindheimer, who's one of the older attendings. This is my lab, people who collect samples, and that's my husband. And we are here to save moms. And I kind of pulled out these hashtags from ACOG, every mom, every time, and not on my watch. So kind of getting the message here that we are here to protect our mothers and babies. Thank you.
Thank you, Dr. Sarosh Rana. This is Dr. Kamini Rao here in Bangalore, the organizer for the Life Conference, and Revati is here on my side. Okay? So, thank you for keeping awake at this time of the night and giving us such a fantastic talk. In fact, when Revati started working on the subject with you, I didn't think that it would become such a big subject. And there's so much of fallouts out of that study. And I would like Revati to say a few comments about this paper. Come.
Thank you.
Thank you so much for that elaborate talk, Dr. Sarosh. And I mean, you threw a lot of light on how we can even modify the postpartum, complications by looking at the markers antepartum, and so much that goes for preventive obstetrics. There's, I think, a lot of secondary outcomes which will come in our study that we did together. So thank you so much for spending that time now in the middle of the night. And
So correct. So I think the way that I see it being used, and you can use it either ways, but I think the way I feel the most importance is in our setups, like in your setup, when you use it as to find out who's the patient who's at risk and then somehow modify her care. So we don't have treatment right now, but in the absence of treatment, you can just do intense surveillance like you did in your study.
Yes.
And when you do intense surveillance, you ought to
That
reduce
makes a
the
huge
adverse
difference.
outcomes. And I think that's where the field is going to be. The study that you did, I have to tell Dr. Rao, of course I know you because I go on the internet and I see who's the organizing person. So I know that you organized the meeting. That's amazing. It's beautiful. You guys, by the way, look really beautiful. All your beautiful clothes. It's fantastic. But yeah, so the study that obviously Revati did, lots of hard work. It's going to be, we'll try to publish it in a high impact journal. But I think that's one of the only studies I can think of is actually one of the first studies done to look at the clinical utility by a clinician in the clinic. So I think hopefully Revati will become even more popular. But I think it's going to be shedding a lot of light on how we should be using this. I think it'll be a very good study, and Revati should talk about it. I know we are going to the AICOG, so we're going to meet there. I'm looking forward to meeting everyone, and I know that Revati is talking about biomarkers there as well. So thank you so much for inviting me.
Thank you very much, Dr. Sarosh Rana. Should I say good night?
Yes, please. Thank you so much.
Bye-bye.
Bye, Revati. Take care.
Bye-bye.
Thanks, Dr. Rao.
Bye-bye. Bye-bye.
Bye-bye. Bye-bye, everybody.
To afternoon session.